Morning, everyone. I hope you're well. Welcome back. Monday morning again. As I said in my message to our Facebook group, I think this last week has just absolutely flown by. Everything is looking good on my end. I just pop a message in the chat. So, any questions? Pop them in the chat box. And firstly, it was really good to see some people in real life. We went to Glasgow University last Wednesday, and what a great lab that was. It was really good. So thank you for all of those that came along, and a few that watch live with us every week. So that was really good to meet people that I've just seen as a name flash up online. So that was really good. Morning, everybody. Our next lab is London, July 7th, I think it is. I think it's a Tuesday. So if you're interested in coming to the labs again, this one in Glasgow was really well attended. So that was really good. We had and we're going to do another one by the looks. But maybe at a different university. So we'll see. So if anybody is interested in doing a Scotland one again, then if you go to clinicalanatomy.education, and there's a button on there where you can leave your details, and you'll get included in the mailing list, so that you'll get kept in touch with whenever anything new comes up. So we're just in talks now with the uni to try and sort a date. So obviously the teaching of the students there, the med students, is the priority for the university. So we have to fit in around them. So that's why we have the dates that we do. It's not because we've chosen those dates. Those are the ones that are left. And so that's why it's July in London, because all of the teaching will have been done by then. And so if you want to do London, that's available now, so you can have a look at that. And if you're interested in Scotland, then that'll be coming online soon. Good morning, everyone. I posted as well. I think I put it in my bag. I haven't got it here. Just got a new book, head and neck book. Looks really good. And it's Roger Kerry was one of the reasons why I got it, because he is really good with all kind of head and neck concussion and VBI issues, that kind of thing, and how to screen for it. So I just wanted to get an update version, so I'll post a link to that book in the group as well when I get a chance. Right, let's get going. This is where we finished. So we did the anterior compartment of the thigh, and let me just scooch back a few slides, just go over. There we go. This is what we were talking about. And we had a look at this for real on Wednesday, which was really cool. We were looking at the IT band, and then you could then track the attachment of that IT band via this septum. So we were having a look at the septums and where they go, and you could see how they divide their leg up. So that was really cool, or the thigh in this case. That was really cool. So we've had a look at this area, had a look at all the muscles in that area as well. And now I just skip forward a few slides again. There we go. Now we're on to the medial parts. This is the inside of your thigh. And so we'll go over a table so that you can screenshot it, and you can use that for revision if you want to, or you can create your own if you want to as well. And then we'll go through the video to just have a look at it in a bit more detail. So this one of the biggest muscles in the biggest muscle in your inner thigh. And there's an easy way. There's a couple of easy ways to remember the muscles of the inner thigh, they don't necessarily kind of I don't know, not necessarily fit into the compartments that we've been looking at so far. So, but if you just had adductor muscles, muscles that adduct the thigh, which is bringing the thigh in towards the midline of the body. Abduction is taking away. To abduct something, you've taken it away. So if you bring, if you're in an anatomical position and you bring either your arm or leg away from the midline, that's abduction. And then bringing it back in is adduction or adduction. Hence the adductors. They are mainly supplied by one nerve, but this one is a bit of an exception. So, and this one's an exception as well because of the orientation of some of its fibers too. So it's kind of two muscles in one. And if you want to remember all of the adductors, then you can there's I don't know what you would call it. It's kind of a mnemonic, I guess, but it's three. It's not really a mnemonic though, but three ducks pecking grass. A saying, let's say. So three ducks are your three adductors. So we've got adductor brevis, which means short, adductor longus, which means long, and adductor magnus, which means massive. Okay, so adductor brevis, longus, and magnus, those are your three ducks. Pecking is pectineus, and then grass is gracilis. Okay, so three ducks pecking grass, those are your adductor muscles. All right, and the order in which they go in, which is quite useful as to work out where things are, is please baby love my groin. Okay, so there is a bit of a relationship with at least that saying and where we're dealing with the body. So the please is pectineus, baby is brevis, adductor brevis, please baby, love is longus, my is magnus, groin is gracilis. Okay, so there you go. Three ducks pecking grass, wherever you come from. So the interesting thing with this muscle, one of the inner thigh muscles, is this bit around here. So this bit here is called the adductor hiatus. So we've got an opening on the femur so that things can pass from the top part of the thigh, so the anterior part of the thigh, through to the back of the knee. Okay, and we'll have a look at this in a bit more detail when we get to the blood supply. But there's a massive blood vessel that comes over here, and then it runs along here and then goes through that gap and then comes out the back. Okay, so we'll have a look at that, and that's something that we had a look at on Wednesday. So we've got origin and insertion, or the proximal and distal attachments, however you want to call it. Inferior pubic ramus. So remember, the ramus is a branch. So the inferior pubic rami is here. Yeah, so that's there's the pubis, and this is the inferior branch of that pubic bone. So that's the attachment for your magnus. The ramus of the ischium. So this is the ischium here. So we've got a branch coming off the ischium as well. It's pretty much divided halfway along. And then the ischial tuberosity, so that's your sit bones. All right, so it's got quite a broad attachment for this whole this massive muscle, basically. So all around that area there. And I've put here that it's the fifth hamstring. So we've talked about adductors, adducting the leg, so bringing the leg in towards the midline. But this adductor, because of the orientation specifically of this bit here, it does help in extension. Okay, so it's part of the hamstring group. And you go, well, how come there's only three hamstrings? Why have you called it the fifth? So the fourth bit of the hamstring is the biceps femoris split into two. Okay, so you've got semimembranosus, semitendinosus, and then biceps femoris split into two, so long head and short head. And then this is the fifth one, the adductor. So we'll have a look at the hamstrings in a bit more detail in a sec. So this is quite an interesting one, because sometimes you can test the adductors and it it feels okay. You test into extension and it's sore, and you think, oh, it must be a hamstring, but actually it could be the adductor magnus as well, contributing to that. Yeah, the nerve aspect with this. Remember, I said that most compartments have got one nerve supply. Well, the nerve in that compartment supplies those muscles, but this this muscle in particular has got two nerve supplies. So we've got the obturator nerve, which we haven't covered yet, and then the sciatic nerve. Most people have heard about that, and this makes sense because of the two actions of the muscle. So the obturator is adduction, and then the sciatic is extension. Okay, so we've got two functions of this big muscle. So if because of what it does and the size of it and the different actions of it, then you can get injuries to the adductor magnus. Okay, so it's quite a common one. Right, let's have a look at these. There we go. So this should hopefully be adductor magnus. There we go. All right, let's have a look at this one. There we go. So this image here, this is from the Trail Guide to the Body Book by Andrew Beal. I think I've mentioned that before as well. It's Biel, and that he's got some really nice images. But I think this is really good because it shows I mean, again, well, you're about to see what a cadaver looks like, but you can see the divide between the two muscles. So the adductor part and the extension part, and the hamstring part. Quite clearly on this image, but it's not as clear as that when we see the actual tissue. And then the adductor hiatus just here, that is really clear. Yeah, you can see that, no problem at all. So let's have a look at this as we layer this on. There we go. So there's the adductor magnus. It attaches onto the adductor tubercle just down here, and there's the hiatus, which is the hole, and they're going to put the knitting needle through the hole because that artery goes through there. Okay, so it comes through that hole. We'll talk a bit more about that as we add on the blood supply. So you can see the really broad attachment of that muscle at the top. I'm just going to play that one again. So yeah, really broad attachment. So that inferior ramus of the pubis, and then the ischial tuberosity. There's the muscle itself. So it's quite a big muscle. Hiatus there, where the blood vessel comes through, and it's a continuation of that vessel. It's exactly the same vessel, it's just given a different name depending on where it is. So there's the back of it. Look at it wrapping all the way around there, and then up there. Okay, so it's like looks like a wing. Okay, really massive muscle, hence the name adductor magnus. It's the biggest one in that region. Cool. So that's one of your medial compartment. This is another one. So this is adductor longus. So this is the long one, and we've got anterior surface of the pubic body. So around this area here, this is really close to where it's, especially in guys, you're likely to get a sportsman's hernia, and it can be often confused with a hernia, so a herniation around here. We did a whole series on herniations, inguinal herniations, I think it was a couple of years ago. So if you have a search through some of the videos, I talk about how they occur and what kind of symptoms you get and why they occur, all that kind of stuff. And it's really close to this region here, as especially in guys, because this is where the spermatic cord will come through down into the testes. So there is a gap around here, and if there's abdominal contents is going to herniate, then it will it can come through that area there. So you can get irritation around this area, and you think you have having an inguinal hernia, inguinal hernia, and but actually it's the muscles attaching around this area. It's more of a tendinopathy. than it is a hernia. So it's a what we call a sportsman's hernia, and this muscle could contribute to that. There's some more as well, which we'll have a look at. But that's your adductor longus. Again, there you go. There's the action of it. So adduction of the hip, hence the name. So it adducts the hip and it's long. All right, so let's have a look at this one. Let's get that. Oh, we've got 2 in 1 there. Yeah, so bear with me a sec. Let me just do the other one as well, and then we'll have a look at that. I'll just skip. Oh, we haven't got it. Oh, we haven't got brevis on there. I thought we did. Bear with me a sec. Let's have a look at this. Yeah. Let's get rid of that one and that one. Here we go. So this is longus and brevis together. And before we move on, so we've obviously just had a look at longus. So adduction is bringing the leg in. Longus is long. Brevis means short. Okay, so we've got adductor short one, adductor long one. Okay, so those are your 2 that are, they're fairly close together. You'll see in a sec. They attach slightly different places. So there's your adductor magnus. There's brevis. There, so there's your pubis just there, and then there's longus there. So they kind of cover. We'll just go back a bit. There you go. Let's get that one, and wait for longus to come on. There we go. Just pause that there. Cool. So there's your brevis, that one just there. There's the longus, and then there's magnus underneath. So they sit in kind of layers. Yeah, so we've got these layers coming down like sheets of muscle. Adductor magnus is the big sheet, and then brevis and longus lie on top of that, and they're attaching onto the femur just here, and then up around the pubis. And again, brevis could be involved in that sportsman's hernia type thing, that tendinopathy issue. And there is another muscle up here as well, a little one called pectineus. So and that attaches around this area too. So it's a really short adductor muscle. And again, that one is out of all the groin muscles, pectineus is usually the problematic one. Okay, so it's up around here. And yeah, it's all around that, just off the pubic bone, all around that area there. So it's they're attached quite deeply around this area because there's a lot of tissue there. But you can palpate this area here, that pubic region, and quite often it's very tender if there's a problem there. Okay, so we've got brevis, short one, longus, long one, magnus underneath, and they all stack in like sheets. Okay, and you can see that they're really quite big muscles there. And there we go, there's the attachments there. So there's your pubis, and then those are your attachments there. So longus and then brevis just there. So they're really close to that pubic bone. And then this is where they attach on the back. So magnus, and then this is the linea aspera. So we've got brevis there, and then longus just down there. So they're quite broad attachments too. So they're powerful muscles. Yeah, and then we've got this adductor hiatus just there. Cool, which we will have a look at a bit more on this one. Okay, so this is that region around that hiatus. Here we go. So there's vastus medialis, which we looked at last week. Adductor magnus, so the big one. Then longus, and then brevis. So you remember how they were all stacked and layered. And we've got this canal. There's like a groove just here. Just pause that there. Yeah, so you can see this groove in the thigh. It's quite amazing, really. It literally is like a valley, which heads towards that adductor hiatus. Just play that there. So there it goes, and then there's the hiatus just there. It's literally like kind of guiding vessels down towards that hiatus. It's covered by your sartorius muscle as well, that canal, so it's protected. So the reason why we can see it there is because sartorius isn't there. And then when you put sartorius over the top, it forms a lid over the top of this area here. So there's your hiatus. And then it will pop through to the back of the knee, your femoral artery from here. So we'll add that out on as we get to the blood supply. Yeah, so there's your sartorius. We had a look at sartorius last week. Cool. Okay. And then we've got gracilis. Let me just, I think we've already had a look at this one. We did sartorius and gracilis together just because of the video. So let's go over this one. So we've got gracilis up here. So this is, again, up around that pubic region. Now this one crosses the knee and attaches down onto the tibia. Yeah, so all of the others that we've been looking at, so magnus was around here on that adductor tubercle. Longus and brevis were up around this region here, but this one comes all the way down into here, and it's called the Pezanserine. Again, if you remember from maybe I think it was last week, we did this Sargent group, so sartorius, gracilis, and semitendinosus, all attaching into this area here, and it can be, again, usually quite a tender area for people. You can have tendinopathy there as well. This one, you can well, when you're testing the adductors, you can test them in a couple of different ways. So if you hold above the knee, okay, and you get someone to adduct their thigh, then you don't activate gracilis, okay, especially if the knee's bent as well. So you shorten that muscle. Put your hand just around about here. You take out the main action of gracilis. But if you straighten the leg and then hold sort of mid tibia and test the adductors, that's going to bring gracilis into it as well because of the attachment point. Okay, so if I push here, then this muscle is going to have no significant impact on that adduction. Yeah, because all of the muscles that attach here and onto the pubis, those are the ones that are going to be activating to do that movement. Whereas if I come down here and do it, then you're going to get gracilis as well. So it's a good way of trying to differentiate between, is gracilis involved in an adduction issue? Okay, so you can bend the knee, test above it, or straighten the leg, test below it. Okay, it's not 100% foolproof, but it's pretty useful. Okay, if you've got a tear in gracilis, then it probably won't hurt if you adduct above the thigh. Yeah, but it will do if you probably if you adduct from the tibia. Hopefully that makes sense. So let's just have a quick look at that one again. And this one had sartorius in it as well. Just get that one back. There we go. So this sartorius was the one that formed the lid over the canal as well. So it kind of brings that into it as well. A bit of a recap on that one. So there we go. So there's sartorius there. And now, so that we looked at this one last time, and we were concentrating on here, we were concentrating on all the anterior musculature. But now you can see these muscles popping through, and we've just had a look at those. So we're starting to add those into the mix now. So we can recognize some of these adductor muscles too. So yeah, there's your sartorius coming down. And again, nice picture from the Trail Guide to the Body Book. And then there's gracilis, which is that one just there. So you can see how it forms this kind of V shape. Yeah, and we'll be talking about that in a little bit more time when we get to the hip area. And then there's your Sargent group, the Pezanserine area, which means goose's foot because it looks like a goose's foot. So we've got 3 muscles that attach around here: sartorius, gracilis, and semitendinosus, which we'll have a look at hopefully today. Just checking the time. Cool. Perfect. So that's your gracilis as well. And then posterior compartment, we are looking at the hamstring group. Right, so we've got semimembranosus, and again, really, really long names. So if you're starting to learn anatomy, you're like, oh my God, what the heck does that mean? Or how am I going to remember this? The easiest way to remember is if you understand. And the reason why it's called semimembranosus, or if we break up the word, semi is half, membranosus is membrane. Okay, so it's half membrane. So it's very flat muscle. Okay, and the membranosus sits really quite close to the femur, and then there's another hamstring that sits on top of this. So we've got two that are grouped together on the inside of the thigh just here. So there's your fibula. So this muscle attaches down here onto the back of the tibia, yeah, and comes from your ischial tuberosity up here. And there's another hamstring that lays over that one, and this is tendinosus. And if you have a look at the word again, you break it down, so it's half tendon. So it's got a really long tendon, this one, and it's quite easy to find. So, and you can do it on yourselves now. So if you have a feel on the back of your knee, on the inside of your knee, and if you scrape your heel along the floor so that or against your leg of your chair, whatever you're sitting on, and if you have a feel right at the back of the knee, on the inside of the knee, you'll feel a big tendon just pop up. If you can't feel it, just relax and then do it again, and it should just ping into your hands. And that big tendon that you can feel, it's about the size of your finger, that is that bit of semitendinosus. Okay, tendinosus is on top of membranosus, so that's a good way to remember it. Tendinosus on top. So this is half tendon, the other one was half membrane, and we've got video of all the hamstrings together. So I'll do the last one as well. This is biceps femoris. So this one here. This is so remember the last two went this way, so they went onto the back of the knee, just down here. This one comes this way, okay, and onto the fibula head just there. So they've got two start points and one end point, and the end point is on the fibula head. Okay, so that's the bone on the outside of the tibia, outside of your leg. This little muscle underneath here, this is the short head, and then this one here, this is your long head. So the long head goes up to the ischial tuberosity, which is your sit bones, and the short head comes onto the back of the femur. So if we have a look here, we've got ischial tuberosity for long head, that's what LH is. Linea aspera, so that's the white line, remember that, we've had quite a few muscles attaching to there, and the lateral supracondylar line, condylar line. So this is the condyle of the femur. Supracondyle means superior to that condyle. Okay, so there's a little ledge just there, and the biceps femoris will attach onto there. Okay, the short head. So we've got short head there, long head there, and they both insert, well, the distal attachment is the head of the fibula. All right, now the really interesting thing with this is clinically, the sciatic nerve usually is one nerve coming down, but it can be two from really high up. And again, we'll talk about that when we get to the nerves. But as it comes through here, it passes between the two heads of your biceps femoris, and as it passes through, it can become sensitized on that journey. So sometimes if somebody has hamstring problems and they are recurring hamstring problems, and you have a scan done, have an MRI or ultrasound, and it's all clear, but they feel it in their hamstring, it may be some mechanosensitivity of the nerve as it's passing through those structures. And you can test that by doing neurodynamic testing, and then you do some exercises, say specifically, but targeting the neural structures, and then retest the hamstring, and usually the symptoms start to ease. Okay, so if you stretch the hamstrings and you keep on stretching them, and it's not making any difference, then maybe it's not the hamstrings that are the problem. Maybe you need to have a look at the mechanosensitivity of the neural structures, and it's because they're sensitized as they're passing through those regions. Okay, so you can, if you have a look at, there's a really good book by David Butler. I think it's called Neurodynamics. Michael Shacklock's book is good as well, but it's really deep. So if you want a kind of lighter, happier version, then I think David Butler's one is really good to start you going. And then if you want a bit more detail, then Shacklock's good as well. I mean, David Butler goes into detail too, but I think Shacklock's book is a harder one to digest than David Butler's. So yeah, it's really, really common. It's also really common in the calf. Yeah, because obviously that nerve will continue down into the calf. So if there's calf issues and they keep on feeling like they've got tightness in their calf, they're stretching their calves and it's not making any difference, it could be the mechanosensitivity of the nerve that is creating that sensation of tightness. Okay, because that's what tightness is. It's a sensation of perception. Okay, so yeah. So I'm just off on one there. Let's have a look at the hamstrings. Here we go. So I've got two videos here. So I've got hamstrings at the knee, and then I've got a more detailed view of the hamstrings as a group all together. Hopefully, here we go. Okay, so this is focusing just on the knee, which is obviously good for us at the moment. So this is the back of the knee. Just going to pause that there. So if we have a look, we can see these tendons running down here. So just to give you an idea of the what's gone on so far. So we've got skin layer, subcutaneous fat, superficial fascia, and then the connective tissue, the fascia that surrounds the muscles, that's all been removed so that you can see the muscles a lot more clearly. And yeah, so you can see the individual tendons really nicely. You can see the back of the knee just here. Yeah, and this is the leg. So we're looking at the back of the calf, that kind of area. So just to give you a bit of an orientation. So we've got semimembranosus, which was half membrane. Yeah. And then semitendinosus, half tendon, and tendinosus is on top, so it's more superficial. You can feel that one, as hopefully you just did when you did that drag back. So those are the two that are coming medially. Just move me out of the way, there we go. So you can see those two there. And they're both attaching a fairly similar place, but one towards the back and one just around towards the kind of anterior medially. So around there. Yeah, so they're both really, really close to each other. And then this is the biceps femoris on the lateral side. Again, so we've got two heads there. Two heads on the femur, biceps femoris. There's your ischial tuberosity attachment there. And that's the start of the short head on the linea aspera. And then they both join together and they attach down there onto that fibula head just there. Okay, so that's around this area here. So you can feel that attachment really easy as well. So last time you went inside of the knee, so medially. This time if you go laterally, outside of the knee, drag back again, and the big chunky tendon that you can feel on the outside this time, if you follow that all the way to its end, it finishes on your fibula head. Okay, so you can should be able to feel that on the outside of the knee, just there. So that's where they finish on the knee. So you got one on the back of the tibia, one on just on the medial aspect of the tibia, towards the front, so anterior medially. That's the pes anserine area. So semimembranosus on the back of the tibia, semitendinosus sneaking around the front a little bit, and then both heads of the biceps femoris coming down, joining together, and then onto the back of the fibula head. Okay, so that's those. And then this is the hamstrings in a bit more detail. So this is from the ischial tuberosity as well, so kind of trying to link the two together. Remember, we were saying that rectus femoris at the front, because it crosses two joints, is more likely to get injured. And all of these cross two joints, apart from short head. So that's why we often get hamstring injuries, but it's usually biceps femoris that gets injured. So there's your biceps femoris. There's semimembranosus, semitendinosus just there. So you can see them all as a group together. So semimembranosus, semitendinosus. So this is the inside. And there it is coming up there. So that's your sit bones just there. That's your greater trochanter. We'll look at, there we go. That's it just there. Ischial tuberosity there. And then the back of the tibia just there. See, it's a massive attachment point, really, really big muscle. Tendinosus on top, there's the tendon. So there's your attachment on the sit bones, and then it's coming all the way down and then attaching there. So anterior medially on the Sargent group, sartorius, gracilis, semitendinosus, which is this one. So that's all three there. And then again, sit bones, this time we're going laterally. So we've got two heads, biceps, two heads. Long head is here. Short head is coming in here, and then they're joining together. So there's the attachment there. So that's for the long head. There's the short head attachment. So that's the linea aspera just there. You can see that white line on the back of the femur. And then they both join together. Here we go. So that's where they're joining, and then all the way down onto the fibular head. So just there. So that's why if you have a feel on that lateral aspect, you can feel the biceps femoris attaching into there. So let's just have a look at that again. So semimembranosus medially, semitendinosus medially as well, biceps femoris laterally. So there's membranosus, long flat membrane, attachment up on the sit bones up here. So that's your ischial tuberosity. And then down onto the back of the tibial condyle. Again, ischial tuberosity. This is semitendinosus this time. So we've got a long tendon. There's the tendon. And that's the one that you can feel medially. So if you do the drag back medially, ischial tuberosity, and then it spins around onto that pes anserine, so that Sargent group where you've got sartorius, gracilis, semitendinosus. Okay, so you can see how quite closely that they all fit together. And then here's the last one, biceps femoris again. So we've got long head coming down here, joining in with the short head. So the short head comes off of the back of the femur. So there's long head. There's your short head. So these are the proximal attachments. And then distally, so further down, they join together. Here we go, there's the join. And then you follow it all the way down onto the fibula, just there. There it is. Okay, cool. Muscles done. That was good. Right, let's just bring that back. Just make sure there are no questions. It's all looking good. So what time is it? Oh, perfect. 40 minutes. That's not bad. So all of the muscles done now for the around the knee. So we've got we haven't covered those small adductor muscles because they're more to do with the hip. Okay, so we've got what one's mainly acting on the knee, though we have done a couple that just act on the hip, but there we go. It was easier to group some of them together. But we'll fill in some of those muscles, so that pectineus that we were talking about today when we get to the hip. Around the knee, we've done all the compartments now, and we've had a look at the muscles in those compartments. And what we'll do next week, we'll start to add in the nerve and the blood supply and just finish off the anatomy for the whole knee. Okay, once we've done that, we'll then go back to the bones and the joints again, and then we'll start looking at the pelvis and the hip, so how that all then links together for the knee. Brilliant. If you're in the Facebook group, any questions, pop questions in the group, and otherwise I will see you next Monday 10 o'clock. See you then.